Welcome to the HealthspanMD podcast. Welcome to the HealthspanMD podcast, where we talk about the science of longevity. How many of you feel like you're getting valuable insights and advice from your doctor about living longer and staying healthy? When was the last time your doctor told you that you could actually slow down aging and extend your healthy years of life? My guess is that for most, the answers to these questions are no and never. Most doctors don't talk about longevity and staying healthy because that's not how we're trained. The healthcare system is built and doctors are trained around waiting for something to go wrong, then trying to fix it. Think about your last doctor's visit that wasn't for an acute illness. What was done? Probably you had a standard set of tests like blood pressure, cholesterol, comprehensive metabolic profile, blood count, and hopefully you were told everything looks good, see you next time. But what if your goal is more than just not to have disease? Is there anything else you can do to identify your opportunities to avoid future health problems? Well, the answer is absolutely. And today we're going to talk about the 10 essential longevity tests you're likely missing but shouldn't be. So I'm going to start with test number one that I do in every patient in my practice, and that is for lipoprotein little a. So, most people are familiar with LDL cholesterol. That's part of every standard profile, but few people have heard of LP little a or lipoprotein little a. So lipoprotein little a is the most common cholesterol genetic variant that is associated with early artery disease. So LP little a is just a separate protein on the LDL particle that leads to it being more likely to cause artery disease, atherosclerosis, stroke, and also narrowing or calcification of the aortic valve called aortic stenosis. And LP little a affects about 20% of people. So I absolutely get an LP little a in any of my patients who have a family history of heart disease or any indication that they have more predisposition to artery disease than I would otherwise expect. Now, having a high LP little a is a purely genetic thing, or at least 90% genetic. You don't do anything to earn that. You either have it or you don't. But knowing it, is really valuable information, because knowing that you have a high LP little a, while we don't yet have treatments for high LP little a, they're coming. We know we have medicines that can dramatically lower LP little a. We just don't know that they change outcomes yet. But I will say that doesn't mean that there's not anything to do with it. My experience with LP little a is long. I had 20 plus years. When I was at Mayo Clinic early in my career, I was the prevention cardiologist, and people would show up with a high LP little a. Nobody knew what to do with it. They'd send them to me. I didn't know what to do with it either, but I said, well, what makes sense to me is I'm going to get their cholesterol great, their blood pressure great, their blood sugar, insulin great, get their habits aligned with their lifestyle or their healthy goals. And what my experience has been is those people have done really well, like decades of really well. So I don't believe LP little a is something that there's nothing you can do about it. I think it's something that's critically important. And by knowing, not only do you have valuable information for you that can guide the aggressiveness of your prevention regimen, it also is essential for your family to know this. So your siblings, your children, to know if they may have a high LP little a as well. And I rarely have a patient show up that's had a LP little a checked. So the next two tests all encompass the same thing. The two tests are fasting insulin and hemoglobin A1C. So both of these are measures of insulin resistance. And insulin resistance is arguably the most important health problem in the world. There's a registry study called the NHANES. It's the biggest population study of Americans, ever, been going on for decades. And they looked at the population, a non-selected population of people in the United States, and found that 93% of them had at least one sign of metabolic disease or insulin resistance. Now, most standard laboratory testing, you get a comprehensive metabolic profile. It's going to have a fasting glucose level on that. But if you truly want to know what your metabolism is, we need more information. And that's where the fasting insulin and the A1C come into effect. So the fasting insulin is a key marker for insulin resistance. And I didn't do this early in my career because it just wasn't part of our standard protocols. But what I've learned is that it really is essential for me to assess somebody's metabolic health. And what I've learned over time is that certainly it's elevated in the times when it seems obvious. Somebody with diabetes, oftentimes, it isn't, long-term burned out diabetes, or pre-diabetes, almost always their insulin levels are really high. But there's also a population of people that have normal blood sugars, but their insulin levels are high. They generate a lot of insulin to keep those blood sugars down. And that manifests in different ways in different people. If somebody comes in to me and says, I eat well, I exercise, I just can't lose the weight, almost always the reason is insulin resistance. If they have fatty liver, they have low HDL, high triglycerides, now I understand those are all manifestations of insulin resistance. The other one that's really common is when people gain their weight around the middle. They're like, I'm okay, but it's this belly. I can't get rid of this belly. It's really driving me crazy. Very commonly, that is insulin resistance. And the other tool of looking at insulin metabolism that I like to get in all my patients is a hemoglobin A1C. So, hemoglobin A1C, unlike a fasting insulin, which is a point-in-time measure, the hemoglobin A1C gives the average blood sugars over the last 3 months. So that's really valuable to kind of put in the spectrum of insulin metabolism and resistance. Where does somebody sit? Now, I will give a caveat of the A1C. There are other things that can move the A1C besides blood sugar. So I do have patients who have really great blood sugar insulin metabolism, and they have a high A1C, and that's not related to their blood sugar. But as a general tool, it's really valuable information if your goal is longevity. You want to know how you're going to live a long time. Well, avoiding insulin resistance is going to be key to that. You have to know where you are. That's where the fasting insulin and A1C come in. Another test that I get in all my patients is a uric acid. This is often an overlooked test. Uric acid will be checked in general traditional medicine if gout is suspected. And, uric acids are high in gout. That gout is an inflammatory arthritis. Generally affects the big toe. If somebody says, all of a sudden I woke up in the middle of the night and my big toe was on fire, likely that is gout. There are other manifestations of it. But, more recent research has shown that uric acid is also a great marker for metabolic syndrome and also cardiovascular risk. And the other thing I like about the uric acid is it can be an early warning sign that maybe there's some tweaks we can make in the nutrition system for that individual that can really be powerful. One, in helping them avoid gout in the future, but also in improving their metabolic health as well. There's also some intriguing evidence about uric acid being a driver for high blood pressure. That's not in all comers, but I always tell my patients it would be really embarrassing for us if we're treating your blood pressure with medications and find out that, it was uric acid the whole time that we should have been paying attention to, or sleep apnea, or whatever that is. And so, when we start looking at the root causes of problems, really understanding metabolic health, uric acid can be really helpful for that. Test number 5, and this is getting a lot more common now, but it's imaging of your arteries. So there's 2 tests that can be done to look at your arteries to see if you have artery disease, and doctors would call it subclinical atherosclerosis. That just means before a heart attack occurs, or a stent. The 2 most common ones, a CT calcium score. That's an X-ray test. usually widely available. It costs generally around $100. Insurance doesn't cover either one of the tests. And what it's looking for is calcification in the heart arteries. Why is that valuable? It's valuable because when we know the risk, we are really great at preventing heart disease. But understanding the risk can be really challenging. Once somebody's had a heart attack, we already know, okay, well, your risk is high because you've had a heart attack. But, here's the really striking thing that I think is under-recognized. A third of people, their first sign that they have heart disease is they die. Sudden death. So waiting for that event to occur to determine that you're at high risk to implement strategies that we know are really effective just doesn't really make sense. And so when you don't know what your risk for future heart disease is, really common scenarios where this is critically important, you have a family history of heart disease, or you have a high cholesterol that you're wondering if you need to be treated for or not. This is a time when a CT calcium score, or the other way that we do this is to ultrasound, an ultrasound of the neck arteries. Carotid ultrasound. Carotid ultrasound can be done for two different reasons. One is to look for blockages. The other is to identify risk. And really what we're looking for in that, sometimes they'll do intima media thickness. That's measuring the wall of the artery as a measure of risk. The best predictor, though, build up a plaque. If there's a plaque in your carotid arteries, that indicates to me that you are at 2 to 4 times higher risk for future events. That may be our, starting point to say, okay, where are we going to stop this artery disease from forming, stabilize this, and we have even really great evidence of regression of artery disease. But if we don't know what your risk is, then we may have missed that boat. Test number 6, hormone health. Hormone health is critical for longevity, but it's often neglected. I'm not an expert in hormone health, but I'll tell you from my perspective as a cardiologist, we've missed the boat in traditional medicine and hormone health. We've really had this kind of spectrum of reaction. When I was in medical school, it was, every woman should be on hormone replacement because it helps prevent heart disease and it helps keep the bones healthy and they feel better. Then there was some research studies subsequently is thought to be flawed that said, maybe there's higher heart risk. And then all of a sudden medicine said, okay, nobody gets hormone therapy anymore. Now that pendulum is swinging back the other way. I'm not an expert at this. Dr. Lisa is. That's what she does in her practice, balancing those risks and benefits. But I'll tell you, not paying attention to your hormone levels may put you at risk of, a lower quality of life, lower mood, affecting cognitive function and long-term health outcomes. So, potentially knowing your hormone health in numbers can be really valuable, whether you're a man or a woman. Test number 7, something that I never did in my practice until about 2 years ago, and now I get this on just about every patient, and that is a measure of muscle mass. I've always known muscle is youth. If we want to stay young, we have to keep our muscle. Maintaining that as we get older, one of the most powerful predictors of longevity. We do not want to be at the end of our life, we paid attention to our blood pressure, our cholesterol, we've kept our weight normal, and we're frail. That's what we're afraid of. And we know from studies that people with that higher muscle mass, earlier the better, but there's really no late time. I've been telling the story a lot lately about my 93-year-old patient who put 2 pounds of muscle on in 3 months. That idea that it's too late, absolutely not true. But you need to know what your muscle mass is before you can create a plan to either keep it or to optimize it. Muscles aren't just about aesthetics or strength. These are metabolically healthy tissue. Having more muscle. Sometimes when I have a patient that has insulin resistance and they're low in muscle mass and they're saying, I guess I need to, eat low carb and I need to do more time on the treadmill. And I will tell them, those things can be valuable and we're going to test all those things out. But I think the most valuable thing that you're going to do for your insulin resistance, for your longevity, for you avoiding being frail later in life, it's going to be building muscle. And so but I need to know that before I can give them that advice. The next test goes along with that. We use DEXA scans to assess muscle mass. The other thing we get from our DEXA scan for body composition is visceral fat. I know most providers in healthcare will pay attention to weight or body mass index, but the reality is these are really crude measures of health. In maybe 10, 15 years ago, there was this kind of conundrum in medicine called the obesity paradox. We had all this observational data that being overweight actually led to better health outcomes in heart failure, in atrial fibrillation. But what we've realized since then is that these studies were done as observational studies, meaning that we didn't know why they had the problem in the first place. And for example, if you have heart failure or if you have atrial fibrillation, well, being overweight can be a risk factor that drives those things, but there's way more scary risk factors for heart failure and AFib, like having heart attacks, having serious valve problems, drinking alcohol to excess. And so it wasn't that you were healthier if you weighed more. It was just a flaw of the studies. But the other thing is that BMI, body mass index, or weight doesn't give you the details. I'll give you one of the best stories I have of this. I'm at Mayo Clinic and I'm seeing a patient for the first time who was a famous football player. And he'd been retired about 10 years. Wasn't somebody who was a lineman. Like he was, a position player that was, known for his speed and agility and all these things. And I looked on his chart when I'm walking into the room, and his body mass index was 38. So the cutoff for morbid obesity, that's the word, morbid obesity, is 35. So I'm like, oh my gosh, this person, this man let himself go. I can't believe, that this happened to him. I'm like really sad. Walking into this, like this was somebody I really admired. I'd always admired from his athletic prowess. This man was Adonis. I mean, probably a single digit body fat percentage, incredible shape, like incredible body habitus. And yet he was listed as morbidly obese by a BMI scale. Now, that's an egregious example, of course, but I think we all have know these things, that there are some people that weigh more because they have more muscle mass and they're metabolically healthy. But that flip side is there as well. Now we kind of know this. We call it the skinny fat. Somebody who's, their weight isn't high, but you look at them and they just don't look like the picture of health. They don't have a lot of muscle mass. Maybe they have a little bit more belly than you would expect. That's where these things can get off. And people, if they're using just weight or body mass index, they can say, oh, I'm healthy. I'm within the normal range. But if we do a DEXA scan and we find out, well, actually your muscle mass is low and your visceral fat, that's the fat around the abdominal organs, is high, boy, that's great insight, because that tells us the opportunities they have to optimize their future health, whereas weight did not. And so visceral fat also, besides being helping me understand where that person's health is now, gives me great insights on how to optimize things in the future. But also visceral fat, unlike body fat, is really predictive of health outcomes. Like, you take body fat, pretty weak connection to correlation between that and other health outcomes. Visceral fat, much more powerful. So I want the best information when I'm talking to one of my patients about their longevity, their proactive approach to their health. I need to know what their muscle mass and their visceral fat is. And then the last thing that I'm going to mention is fitness. So fitness is one of the best predictors of longevity, yet most providers don't measure this. Even if you get an exercise treadmill test, generally that's done to detect if you have artery disease or not. It's not done to assess fitness. But here's what we're missing out on this. Fitness is far and away one of the most powerful predictors of longevity. there's a great study. 120,000 plus people followed for 14 years. From a medical standpoint, this is one of a great research study. And they looked at predictors of longevity in this. And they included things like heart disease and smoking and end-stage renal disease. But they also assessed fitness with a VO2 test. So they knew very precisely what these individuals' fitness was. And what they learned in this is that, yes, the things we expect, like having heart disease, is predictive of your mortality. Increases the risk if you have heart disease versus somebody who doesn't, about a 40% increase in your mortality over the 14 years. But when they looked at fitness, man, that's when the real distinction came in. So people that were at low fitness compared to people at elite fitness, it wasn't a 40% difference. It was a 500% difference. And even going from below average to above average fitness would change the risk of mortality by 200%, by doubling. So fitness, one of the critical things that I want to know about all of my patients, if they are in the frame of mind of longevity and wanting to live a long time. Okay, I lied to you. I thought I was on the last one, but actually that was 9. Here's number 10. Resting metabolic rate. Resting metabolic rate is a pretty simple test to accomplish. It takes 15 or 20 minutes. You wear a mask. It measures your oxygen, carbon dioxide, and tells us how many calories you're burning at rest. And this is really a valuable bit of information, because what most people don't understand is probably like 70 to 80% of the calories you burn in a day is resting metabolic rate. Like, our metabolism is really driven by that number. But if you don't know what that is, then it can be really challenging to find out, like, am I eating enough? Am I eating too little? Am I eating too much? This can be really valuable. Now, there's a lot of details to this. The quality of the calories matter. The macros matter as well. But we need to start with some really good information on how much, because the reality is most of us probably are eating more than we need, but understanding what that number might be can be really helpful in determining what your longevity nutrition plan is as you look to get younger over time. So there you have it, 10 tests for longevity that you probably have not had that you should have. From muscle mass and visceral fat to advanced markers like Lp(a) and fasting insulin, these tests give us a much more comprehensive understanding of your health than the standard blood work alone. If you're serious about living a long, healthy, and vibrant life, I encourage you to seek out these tests and work with your doctor, your provider, who takes a proactive approach to your longevity to help you interpret them as well. So again, thank you so much for listening today. It's really been fun to be talking about these exciting opportunities for you to live that long, healthy life that you have an opportunity to do. And if you don't have a doctor that you like and trust to guide you on these things, then we would love to get a chance to work with you. Just come to HealthspanMD.com. You can schedule a discovery call, find out if our proactive approach is right for you. All of this in the show notes. Thanks for listening. All content created by me and HealthspanMD is for general informational purposes only and is not the practice of medicine. No doctor-patient relationship is formed. The use of this information is at the user's own risk and is not a substitute for professional medical advice, diagnosis, or treatment. Hi, I'm Dr. Hurst. We created HealthspanMD for people who are dissatisfied with healthcare. Common complaints about healthcare include difficult access, poor communication, rushed appointments, disease-focused or sick care with little interest in helping people get or stay healthy, and little to offer beyond a prescription or a procedure for optimizing health. This type of healthcare is unacceptable, but most aren't aware that they don't have to accept low-quality healthcare. HealthspanMD provides exceptional medical care. That means appointments when you need them, time to talk to your doctor, get your questions answered, understand your problems, and get a clear plan to achieving your health goals. But it also means a comprehensive, proactive approach to your health that goes beyond prescriptions and procedures. As a HealthspanMD patient, you will get our expert, physician-led team of doctors, health coaches, dietitians, exercise specialists, mental health, and other health professionals to help you take advantage of your best opportunities to prevent, treat, and even reverse disease. And you may be eligible to have our care model reimbursed by Medicare and some commercial insurance. If you're no longer willing to settle for low-quality health care, schedule an appointment at HealthspanMD to experience health care as it should be.